I don't think it's going to take us the whole time. The other request, as always, is to please, when Ashley sends out the email, in order to get CME credit, you need to fill out the evaluation and get that back to her. That's really important. And so we won't be, we're not recording my part, I don't believe. We will be recording the didactic session, so if you want to refer back to that at a later date, that's always possible. And so with that, Ashley,
I'm recording you too, Jen, just because I know you won't slip up on the PHI.
That's right. Absolutely not. Okay. So I'm going to go ahead and get the case that Dr. Collins and I actually had. This was fairly recent, and we thought it would be a good one to kind of go over because it can show you how it's possible to have something come out of left field. So this is a 53-year-old gentleman with past medical history significant for COPD. He had a remote history of ileocecal resection and reanastomosis in 2002, who had presented to an outside hospital on November 3rd. He was complaining of fever, chills, abdominal pain, nausea, vomiting, and diarrhea that had begun approximately 10 days prior. He was having up to 10 non-bloody, watery bowel movements per day. At that outside hospital, he was noted to have a fever up to 101 degrees. He was hypotensive and tachycardic. He had elevated lactic acid, white blood cell count of 6 with a 21% bandemia. Also notable was a platelet count of 30. He had a total bilirubin of 1.6. Imaging, his chest x-ray was unremarkable. CT imaging of the abdomen was suspicious for potential gallbladder disease. So he was subsequently transferred to CVPH to be evaluated by our surgery department. When he got here, he continued to be hypotensive and tachycardic, requiring fluid resuscitation. He had actually gotten up, I think he had a total of 7 liters between the outside facility and our facility. So when he was here at our hospital, he ended up having to be put on Levophed briefly and was admitted to the ICU. By the time we saw him, his temperature had gone up to 102.3 degrees Fahrenheit. He had remained hypotensive, but they were able to wean him off of Levophed. He then had undergone a right upper quadrant ultrasound that was suspicious for acute cholecystitis. So they recommended HIDA-scan, which was done, and the HIDA-scan was actually unremarkable. It wasn't consistent with acute chole. So oddly enough, while he was here at our hospital, they were doing something. They rolled him over in bed and they found an engorged tick on the guy's leg. So they're like, well, that's interesting. And then when we went and actually met him and talked with him, he told us that he'd found a tick in his right armpit approximately 1 month prior. So again, fever and chills, watery diarrhea for the past 10 days. He was having myalgias. And then he had not had any antibiotics in the past month. No history of IV drug use or anything like that. So he did have, and that ileocecal valve surgery was because of a Crohn's flare that had happened approximately 10 years ago. So by the time we're seeing him, he's been here now for a couple of days. The guy, he lives at home with his wife. They have 2 dogs. He goes out, not a lot. He's not a big hiker in, but he did have an engorged tick on him and a tick bite a month earlier. So when we saw him, his white blood cells had decreased to 3.29. His hemoglobin was 9.8 with a 13% bandemia, and his platelets were 19. BUN and creatinine were unremarkable. Alk Phos was 30. AST and ALT were slightly elevated but trending down, and his lactic acid was normal. He also had a procalcitonin of 18.9. So what do we think? Anybody have any thoughts, questions, comments? Vanessa?
I can here. Mona, I'm watching the chat box too.
Are you? Okay. So we kind of, so at first you're thinking, does this guy have gallbladder disease? Is there something going on that's intra-abdominal that we're missing? He didn't have C. diff. We sent off a whole stool panel. He didn't have any of the common players that you would expect. But he, pancytopenia, he was leukopenic, he had thrombocytopenia, he had an engorged tick on him, which it would have been really early, but then he had the history of having a tick a month prior. And so we sent off, we continued treating him with Zosyn, but we also threw up doxycycline because we were pretty suspicious at that point, looking at the lab work, and sort of thinking that all of this abdominal pathology was kind of a red herring. And so, what do you think he had, Vanessa? What do you think about the, Vanessa, what do you think about the hemoglobin?
Sorry.
No,
Did he have the schistocytes in the peripheral smear?
Good question. No.
Great question, but no.
And did they do the LDH? I'm sorry, I didn't see that.
Yes, we did one. It was elevated, if I remember right. It was elevated. And so I think that certainly was in our differential. So what we did, we sort of said, he's in shock when he came in, so we don't want to bet the farm on it being a tick-borne illness. And so we treated us with the Zosyn, and then we did doxycycline. But yeah, and so as far as tick-borne infections, I think Libes is in there. What else is in there? And anybody, not just you. Yeah. And so, so all the common tick-borne infections we see around here could have certainly been responsible. And by the way, it was a black-legged tick, if anybody wants to know. It was still crawling around. They had it in a cup when we came by the ICU.
Must be nice to be the guy like, oh, we found a bug, call Keith and Jen.
Right.
And they save it for us, which is great.
Right.
Yeah, they always do. They save them for us like we're some kind of tick identification experts.
Well, you've got Leanne.
We do.
That's right. So anyway, to sent off the tick panel, and it in fact turns out that he had anaplasma infection. And so with the treatment with the doxycycline, we started to see resolution of his pancytopenia and resolution of his diarrhea. And the guy, he got better and ended up being discharged home pretty soon thereafter to finish out his course at home. So it was a pretty interesting presentation for somebody with a tick-borne illness.
Do you think that if they hadn't actually found the tick, that they would have gone ahead and done a cholecystectomy? Even though the HIDA was unremarkable?
I don't
think our surgeons would have done it.
Not in my mind they would have.
Right.
And I think given that it was like everybody was kind of looking for, so, but I don't know, like the data just wasn't there. It wasn't compelling. He just didn't look like he had this hot gallbladder. Even on his abdominal exam, he was a little tender, but nothing remarkable. So I don't know that anybody would have zoomed him into surgery. I think he probably would have continued to become more pancytopenic, and we would have started looking for other stuff.
Yeah, so I really do think this was, how old was he, Jen? I can't remember. How old was this guy?
He was 53.
So this is a potentially life-threatening case of anaplasmosis. It really is. He was in shock from it. And I personally have not seen diarrhea be as prominent as it was with him before him. And I also say that the platelet count of 19 was really low, even for, I think, anaplasma. I was surprised by how low it got. But it really did turn out to be that it was all anaplasma and nothing else. So once again, anaplasma has reared its head in our community. We see more people sick from that than we do Lyme. Again, we are referral, so it's probably that. But this guy proves you can get life-threatening ill from anaplasma. And last year, we actually did have a death from anaplasma. So hopefully, we're going to get toward the end of seeing it pretty soon.
Was he on any for his Crohn's?
No.
He wasn't?
No, Lee, our pharmacist, just asked. He was not on any medication for Crohn's disease. He had taken, I believe, I want to say methotrexate perhaps, or he had taken something about 10 years ago, but had not been on anything recently that would have caused immunosuppression.
Yeah, good question, and he was not.
Flared up his.
Keith, where did he live? Do you know?
Is it on our note there, Jen? I can't remember. We do keep track of that.
It's not on my note, but he had gone to Moses Luddington.
Oh,
Which
So,
is where? Where is that?
Ticonderoga.
Yeah.
Oh, okay.
Ticonderoga area.
That
Yeah.
makes sense. So the health department was just telling me yesterday that we've had 45 confirmed cases of anaplasma in Essex County just this past season.
Wow.
45. And the
That's
other
amazing.
thing I didn't know anyone was doing, we're actually plotting the cases by zip code. Just my students are just for fun, and they're all located right along, but either the shore of Lake Champlain or on one of the two rivers, the Ausable or the Boquete. So they're following where the ticks are. Those,
Wow,
you know,
cool.
it's really interesting. But the other really cool thing that you guys might be interested in, they did some genotyping of the anaplasma from that cluster. They call it a hotspot. So Essex County is now a true hotspot for anaplasmosis, and the genotypes are kind of distinct, and they're the more pathogenic.
Huh.
So
Wow.
right, so it's not just one bug; it's many strains. Same with Lyme. So
Yeah.
I don't know. It just something I would love to hear your thoughts on sometime is, and I'd love to have a conversation with you about it. Is kind of the first wave of an infectious disease, especially vector-borne, might possess the more virulent strains that might be causing these more severe disease. It's a subtlety that I don't think you guys usually think about, but it's really kind of intriguing. Right?
No, you got a good point there too.
Yeah.
Yeah.
And didn't we actually have him on azithromycin and atovaquone until the Babesia PCR came back negative? Because I was worried about it. I think we did that. Because it did come back negative, by the way. The LDH was up, but the PCR came back negative, and I think I had him on there for a couple of days and then stopped it. But his anemia got better too. And part of that low blood count could have been a lot of fluid resuscitation because he was in an ICU. And
We're wondering if that was just washout.
Yeah.
But then he kept getting lower. Oops, sorry, despite.
exactly.
I don't know if it was him because unfortunately at the same time we had a couple
Yeah.
unknown origins
Yes.
that were looking the same,
Yeah.
that were presented with sort of leukopenia, thrombocytopenia.
I think I put him on it though. I can't
It
swear
might
to it.
be.
But I think, yeah.
There was
Yeah,
somebody, 3 patients at the same time
Right.
that we were kind of batting these ideas around, and one of them definitely was on atovaquone briefly.
We've had 2 other patients, by the way, just so you guys know, and I'm sorry I didn't bring the presentations of them, but we've had, like Jen was just saying, they were also in the hospital at the same time. 2 other patients, leukopenia, thrombocytopenia, elevated LFTs, fever, all testing negative, all of it. Even PCR for Borrelia myomatoid was negative. Got better with doxycycline.
Exactly. I was going to say they all
So,
got
I
better
don't know
on.
what we're dealing with. Yeah.
But you don't know what any of those were.
No, we never got an organism, but I still think in my heart of hearts they were tick-borne. They both got better with doxycycline, but we found none of the usual pathogens. And we sent
And
off
did they have a history of tick bite?
I can't remember. I don't think so.
That they recalled, but certainly,
No.
could have possibly gotten it,
Yeah.
out.
Most of the time we
One of
don't
them had a
have
history of a tick bite, but they were just, they had exposure, and they acted like a tick-borne illness, and they got better with doxy, but we could not identify an organism. So
Right.
maybe there's something else out there, Leanne, that we haven't found yet.
I bet there are.
Yeah, I bet there are too. Me too.
This
Yeah.
just gets more and more interesting now, doesn't it?
It does. We did a PCR for Borrelia myomatoid on one. The other one, unfortunately, he had been on doxy for several days, and there was no way the PCR for that was going to come back positive. And we did a C6. You guys are familiar with that? A C6 is it's an antibody to a peptide on the Borrelia organism. It's on both Borrelia burgdorferi, and
Yep.
a lot of times it's on Borrelia myomatoid. And so if you order a C6, it can be sometimes a backdoor way to find Borrelia myomatoid if you've had negative Lyme serology, but you get a positive C6. And we did that on one of them, and it was negative. And the other one, we actually got the PCR before the doxy, and it was negative. So I have no idea what the other 2 had, but they seem to improve with doxy, both of them.
And you would expect this to slow down soon, right? With the colder weather approaching. I mean, even
Yeah.
days.
So I guess one thing I would sort of,
Yeah.
I was just going to say one thing I would sort of suggest, unless you've got a clear-cut alternative diagnosis, and we didn't in this case, and we were lucky and found anaplasma, but in these other two cases, you know, rightly or wrongly, I chose to keep them on doxycycline because I just couldn't convince myself this wasn't a tick-borne illness. It acted so much like it. So you may find yourselves in that situation at some point, and if you do, you can always call us up. We can talk about it, but I would suggest at this point, unless you got a clear-cut alternative, there are probably tick-borne infections that we don't yet have identified, and these two may have had that because they certainly seemed to improve once we got them on doxy, both of them.
And you don't think it was just really early Lyme that was not seropositive?
Back on one of them and tested them 4 weeks later, still negative.
Oh, okay.
And I think I did it on both of them now. They're still negative. So good point, but no. I
Yeah.
don't think
So even if there's never the case that you treat it early enough that they never seroconvert, that
No,
usually doesn't happen.
I used to think that was true, but recent data suggests that almost never happens.
Okay. And
so-
a lot of these new things they're seeing in New York, you know, like heartland virus, and are usually viral, you know.
Right.
But
This
a new
acted like
bacteria.
this acted like a bacterial infection that got better with doxy, both of them. I can show you those cases more at some point, and I could maybe present them at some point for you guys too. I should have done one of them today because I got something, but next
Right.
time when we meet, I'll show you one of those because I think it's worth seeing when we don't get it. We just don't know.
God, yeah. Right.
And that was the case here. And we've all, as clinicians, been in that situation where we just don't know and we have to take our best guess.
The other thing I might just point out is Ashley mentioned that should be slowing down soon, but the fall tick season just ended. So the adults were all up and out starting Columbus Day until just when the snow started to fly. But anytime temperatures above 40 or 45, they're going to be up and biting. So it's really, winter is not necessarily a no risk time.
Exactly, I get that too. Yeah.
Kind of when you see the snow fleas out, the ticks will be out too. You know the snow fleas that you see?
Yeah.
You know what I'm talking about. Fine if you don't. They don't bite, but yeah, on those winter melt days, ticks are going to be very active. Really
I've seen the snow spiders. I don't know that I know what snow fleas are.
No fleas.
But...
Anyway, yeah. But insects can be really active, and these guys are really active in the winter. So
Now I have something else to think about. I haven't seen a snow flea, so now I got to look for that.
okay.
Me too.
They don't
Yeah.
carry
Snowflake.
disease and they don't bite.
The one merit that winter had for me was that all the bugs are gone. And so now you're just killing that for me too.
And that.
All right.
Me too. Yeah.
All right. Do we want to move into our didactic?
You guys have anything else you want to throw out, or no? Or we can keep going now if you want.
I think
All right.
All right.
So I know we don't have a case of Lyme carditis this year. We had a couple last year. I think we had one case in the hospital this year that I just wasn't involved in. I think Dr. DeJoss had it, and they had both meningitis and carditis. But I just can't leave Lyme without at least going through myocarditis from Lyme disease, because I think it's such an important topic, because it's one of the few times that Lyme disease can actually be fatal if it's not treated.
And I think it's important to note, you know, one of the 3 patients that we were watching that week, that gentleman had come in with
Oh yeah, I forgot.
And they were talking about, he was having like a sick sinus syndrome with big pauses, bradycardia, tachycardia, and they were talking about putting a pacemaker in him. And so we asked him to just stand by until we could go and see him. You remember, you're like,
Yes.
before, this is maybe just heart block from Lyme disease. They ended up not having a pacer put in. We never proved that it was, but he did improve on doxy. So.
Hey, Jill, I've got something fun for you. How do you feel about sharing your screen? I had a Zoom update, and now I will have to completely take down the session in order to share Dr. Collins' slides. So if you can share his slides, I would be happy to make you a co-presenter.
She's saying something, but she's muted.
You are muted, and so I don't know what you're saying.
As long as you can send them to me, yes.
Yes, you might actually have them from last time, but I will shoot them to you in an email right now.
Okay.
Just bear with us 1 second, we'll get it going.
Those tech updates, they're so lovely and also so dicey. All right, Jill, they are headed your way. Sorry, everybody. So in the meantime, does someone want to explain what a snow flea is to me? Yeah.
Leanne's trying to, I think.
So in the winter, when you step into the snow and leave your footprint, and then on a warm day, you see all this, it looks like peppers. So it looks like someone sprinkled pepper in your
Oh
footprint.
yeah, I've seen that.
Those little things. So they're little and they spring. They're called springtails. They're tiny little bugs that spring around. And you see them on the snow. They're always out there, but you see them on the snow.
Okay.
Interesting.
Next time you're out, look, on a warm winter day, and when it's, but they're not really fleas. They're really cute.
Okay.
They don't bite and they don't carry disease yet.
Good.
So
carry the
I'm
plague, the
finding the
bubonic
old one.
What I
So
sent
let me
you?
get the new one. All right.
I haven't changed it since the last time it was sent, so
Okay, as long as it's the same, then I'm good to go.
I think it's the same. I don't think I've changed it. If you have the same one I sent you last time, I haven't
Yep.
altered it. So I think we're good.
I'm ready.
All
Okay.
right, so you're good, Jill. I made you a co-host, so if you share your screen, we should be okay.
All right. Where did my Zoom share? And I want this. Share. Beginning. Can we
Well
all see
done.
the slides?
That's beautiful.
Yeah.
Thank you.
That's great.
Okay.
I can't wait for you to cover maternity leave.
So yeah, we're going to do cardiac Lyme today because again, I think it's a really important topic for us to go through since it's obviously it's a potentially life-threatening manifestation. So Jill, if you could make the next slide come up.
Sure.
So again, we're going to go through briefly the stages of Lyme disease, go through the incidence and epidemiology of cardiac Lyme disease. It's surprisingly a little bit different than early Lyme disease that we think about. Cardiac Lyme has sort of a few unique epidemiology things about it. We'll go through the features of Lyme Carditis. And I think it's worth at least reviewing the conduction system a little bit so that we get a better idea of what's going on there. And the histology and pathophysiology of cardiac Lyme disease, I also think is pretty interesting. We all know it can cause heart block, but exactly why that happens, I think, is still an open question, which I hope you see. And then how to manage Lyme carditis. And be aware that there is right now still conflicting evidence about a possible association between Lyme disease and the subsequent development of a dilated cardiomyopathy. We will touch on that, but that literature is all over the place right now. Okay. If we, okay. If we can go to the next one.
There we go. I couldn't get it
All
to
right,
go.
great. That's fine. So again, cardiac Lyme is in the same part as early disseminated disease. And so that's, again, where you see meningitis, and you can see cardiac Lyme in that same place where people can have multiple erythema migrans lesions, not necessarily, but they can. And that's the early disseminated part of the infection where it's gotten into the blood and it's spread to other organs, one of them being the heart. And so I think the case that Jean and Jen saw this year had both meningitis and cardiac Lyme at the same time. So again, I just think it's worth putting that out. And then Lyme cardiomyopathy, I think, is a very nebulous concept that I don't think it's proven at this point. Okay. So the true incidence of this is unknown because probably the most people who get cardiac Lyme probably never get an EKG, and they probably never have any systemic manifestations unless they develop symptomatic heart block. So it's estimated that it was anywhere about 1 to 4% of people in the United States who get Lyme can get Lyme carditis, meaning symptomatic. So if you figure out the math, an annulance of 30,000 cases of Lyme in the United States that are diagnosed, about 300 of those are going to have symptomatic Lyme carditis. And so it surprises me that we see as much of this here as we do, because we get a case or two every year. Okay. And again, it's exactly where you would expect Lyme to be, upper Midwest and northern New England, and where we are, northern New England. It's interesting, it has a male predominance of about 3 to 1, and that's odd. Nobody really has a great explanation for why that is. And third degree block, meaning really severe block, has an even higher male predominance, about 5 to 1. And it tends to be younger patients, ages 10 to 45, rather than the older patients. Now, you can certainly see Lyme carditis with heart block in both men and women, and you can see it in people my age. But it's 10 to 45 is where the mean is. And it's interesting that it is such a male predominance, and there's no clear explanation for that at this point. Okay. So again, it's one of the early manifestations of early disseminated disease, and so you can get cardiac Lyme within 3 to 30 days following a tick bite. So they can have other manifestations like we were just talking about. They can have the systemic symptoms, and they can have the neurologic symptoms, as well as the multiple erythema migrans lesions. We had a case last year that came in with all these erythema migrans lesions with cardiac Lyme. It was an easy diagnosis to make in that situation. Patients can present with dizziness or lightheadedness, chest pain, syncope, and sudden death can be their presenting symptom, unfortunately. So on the EKG, first degree is more common than second degree, and that's more common than third degree. And I just want, again, we're going to go through a little bit of, I'm certainly no cardiologist, but we can at least review a little bit of where the blocks are and what they mean. So it's important, I think, to know that the majority of people are asymptomatic. But I think it's probably a good idea to get an EKG if you think somebody has early disseminated Lyme disease, meaning they have Lyme meningitis or they have these other things with multiple erythema migrans lesions. I haven't been doing it, but I think it's probably a good idea to get an EKG in these kind of patients because we could be missing something that could kill them. Okay. So the conduction system, again, I had to review it so I could even do this talk because I don't do this very often anymore. So you have your AV node, you have your sinoatrial node, and then you have the bundles of His, the left and right bundles. And a lot of times the cardiologists will divide heart blocks up to where they're above His or infra-His. And I think it makes a difference because if it's infra-His, they're more likely to get a wider complex third degree block if it's infra-His. So we can move on. And again, this is going through that same kind of thing where the left and right bundle branches are. The His bundle, if you can see, it's below the AV node. Can you see that on that part there? And so that's where a lot of the blocks, if it's below that site, you're more likely to get a higher degree, third degree Y complex heart block that's much more dangerous than some of the other ones. Okay. So just to kind of review the different forms of heart block, as you can see, first degree AV block is prolonged PR interval of greater than 0.2 seconds. Second degree block is where you have a Mobitz 1, which is where you drop a beat. The PR interval gets progressively longer. You can see that in the second part there, where the PR interval is getting longer and longer, and then finally you get a drop beat. And then second degree narrow complex Mobitz 2 is where you have, again, they're associated where you have a 2-to-1 block where you have 2 Ps and then you have the QRS. So that's a second degree narrow complex. And the most concerning is the third degree here on the bottom, which is where there's AV dissociation. And in this case, it's probably infra-His because it's a Y complex tachycardia, a Y complex QRS. So that's your most dangerous one. And that's the kind of person that probably is going to need a pacer, a temporary pacer, if it's from Lyme. Okay, everybody got that? Anybody want to add anything? Because I'm certainly no cardiologist. If anybody knows more of the the heart block stuff than me, that's great, because I don't do this anymore. All right, okay, good. So here is, and I just have to show this because this was the first paper that came out that identified cardiac Lyme. This was it. It was in 1980. It was by a guy named Steer and his colleagues. And they went through, and this is still, I think, one of the best descriptions of cardiac Lyme that's out there, where they identified the symptoms. They gave you what the presenting symptoms were, what the physical findings were, what the EKG findings were. And as you can see, they had all that there. I just thought it was really nice, and it's a paper that I think is really fun to read, and it's good. It's very clinical. Okay. So as you can see, shortness of breath, dizziness, that kind of stuff. Oops. And then this is something that I think is becoming more apparent, is that people can die from this. And there were 3 cases in 2013 that presented as sudden cardiac death. And post-mortem, they found the Lyme spirochete in the heart tissue, including conduction system. I think then at least 1 or 2 of these cases, they also had positive serology. I can't remember all 3 of them did or not. So you can die from this if it's not diagnosed, unfortunately. And obviously, if it's sudden death and they can't get to a hospital, there's nothing much you can do, just like sudden death from coronary disease. But we can at least be more preemptive about having a lower threshold to get EKGs on our patients who might have early disseminated Lyme. Okay. So cardiac Lyme, basically anyone residing or recently traveling to a Lyme area that you think has early disseminated Lyme disease. Even if they don't have the cardiac symptoms, I would suggest that we all get EKGs going forward. If you're presenting an unexplained 1st or 2nd or 3rd degree block and you live in an endemic area, then certainly Lyme should be on the differential diagnosis of new onset, otherwise unexplained 1st, 2nd, or 3rd degree heart block. But having said all this, again, we go back to the serology. If your serology is negative, remember, early disseminated Lyme, the serology should be positive at least 90% of the time. So if you have negative serology and someone's coming in with heart block, even if they live in an endemic area, it's probably not Lyme. It's probably something else, and that person may well need a pacer for some other reason. You're rarely going to see cardiac Lyme without a positive serology. Okay. So I just want to bring this back up. We've talked about the CDC recommendations to testing for Lyme. There is a newer version that is now approved and probably is going to replace the Western blot. And so probably next year we won't even be using Western blot, or our lab will offer the 2-step testing. And what it is, it's an what we do now is the first step is an enzyme immunoassay that looks for antibodies made to specific antigens on the Lyme spirochete. And if it's positive there, then we go to the Western blot. What's being proposed is that they do a 2-tier EIA using different antigens, and that's probably more sensitive and as specific as doing a Western blot. So for instance, you can do an EIA and then you can do a C6. You heard me talk about a C6 today. And the C6 also has some other things that are going to be put in with it. And that's probably going to be the preferred way to diagnose Lyme. It's still going to be negative early on. So it won't have, it improves the sensitivity somewhere around 60% as opposed to about maybe 30% now for early Lyme. But it is going to be the new thing, and we're probably going to move away from Western blot by probably next year. Okay. So this is one thing I just hadn't looked at myself until I started getting ready for this talk, is why do people get heart block from Lyme? And I'm still not sure I know the answer, but I'll share with you what I found out. So it can infect, the spirochete can be in all layers of the cardiac tissue, including epicardium, myocardium, and endocardium. There's abundant lymphocytic infiltrate with histiocytes and macrophages. And there is a characteristic, this is kind of, and I'm going to show you some slides of this, a band-like inflammatory response that seems to be pretty characteristic of Lyme carditis. The transient conduction systems abnormalities are thought to be more likely due to the immune response itself rather than to the permanent damage caused by a spirochete. So it's mostly likely the immune-mediated response that's producing the heart block that's transient. Most patients recover without long-term sequelae or without myocardial necrosis. There are isolated case reports of the infection being associated with dilated cardiomyopathy. This is particularly true. This may be a strain thing. Looks like it could be true for Europe, but maybe not here. And I think I give you a little of that toward the end here. So the jury actually is still out on this dilated cardiomyopathy thing, but the initial stuff here looks like it's probably not true in the US at this point. Okay? This is that characteristic band-like description that they're talking about. Now, on the left-hand side of this image, you see those dark cells, the lymphocytes. They're in a band-like configuration, and you can see another, across there, there's a smaller band there with it. So that's fairly characteristic of what Lyme carditis looks like histologically. And then the stuff in the center is the cardiac muscle, but that's a band-like histiocytes and lymphocytes there. And that's what when they do get histology, that's what they typically see. And they've seen the same thing in animal models too. Okay. Okay. So I just want to point out that children can get cardiac Lyme, and they can also have heart block, and they can also need temporary pacers. And so just as we do in adults, if you think some child has early disseminated Lyme, you should probably be getting an EKG on the child too, because it can happen to them. As if you notice, that age range with the male predominance was age 10 to 45. So it definitely can happen in children. And that's what this paper was about here. Okay. And again, that's the same thing I'm talking about, the fact it can happen in children. As you can see, the symptoms are very similar. They can present with shortness of breath or dizziness, fatigue, passing out, syncope. And then if you get an EKG, you'll see that you'll see first, second, or third degree heart block. And again, with treatment, this also resolves in the vast majority of cases. Okay. Okay. So what was I trying to get here? Okay. Let's see. Oh, this was trying to look for risk factors of associated symptoms that would make you think about cardiac Lyme. And again, it's basically people that would have the things of early disseminated Lyme where they have the risk factors to get a tick to begin with. And they do talk about arthritis, which can be more common in children, I think, than adults, even early. And so those are the kind of things that they're associating that you should think about cardiac Lyme, again, even if they're asymptomatic. I'm just curious, is it when you see Lyme in your clinic, I haven't been doing this, when you guys see Lyme in your clinics, have you been getting EKGs on people that are systemically ill, like they come in with a fever, not just the erythema migrans rash and they look fine, but if they come in with the erythema migrans rash and they're sick with a fever, have any of you been getting an EKG? I haven't, but I'm going to. No? Okay, me neither. All right. Have I convinced you that it's probably a good idea? I hope. Good. Okay. So here we go. First degree, this is again in children. And so they can get the same things that adults can get, complete heart block included, which could buy them a temporary pacer. Okay. And so this was the conclusions of basically it's transient first, second, or third degree heart block. Is what you see most commonly. Fulminant myocarditis can happen where they wind up with this is not a chronic dilated cardiomyopathy. This is a myocarditis that causes an acute cardiomyopathy. That's rare, but it can happen. The most common thing we do see is heart block. That's transient. And it resolves within a week in most cases when you start treatment. And again, children with early disseminated Lyme disease can also get this, and they have more arthralgias. And the ones that have arthralgias are also more likely to have carditis. And so let's go on to treatment, I think is next. Yes, okay. So this has actually changed a little bit in the new IDSA guidelines, which I can't get hold of right now because they took them down. Unless, Jill, you can find them again. Because remember, they had them out for public comment.
Right.
And
I can look for them when we're done.
What's that? I
can look for them when we're done.
Yeah, thank you, because they had taken them down, but the new guidelines in IDSA say that you can actually start treatment with doxycycline if you choose, rather than do ceftriaxone for 14 to 28 days. If I remember correctly, that's in the new guidelines that you can do doxy right off the bat. In reality, what people do, even though this says ceftriaxone for 2 grams for 14 to 28 days, in reality, what people do is they treat with ceftriaxone in the hospital right now, and then when the PR interval gets usually down to like under 0.3 for 24 hours, then they'll switch to oral doxycycline and let them out of the hospital. And I think that's a reasonable strategy. That's what we've been doing. But it's evidently acceptable now that doxycycline can be the only drug you use. But again, if it's cardiac Lyme and they are having signs of heart block, I would certainly want them in the hospital and hospitalize them, even if it's just first degree, until we're sure that things are looking like the PR interval is getting shorter, because multiple papers I've read now have said you can go from first degree to complete heart block within seconds. So just because you come in with first degree doesn't mean you're not going to suddenly go into third degree. It does happen, and it can happen within seconds to minutes. So you really do, oh yeah, it says less than 300 milliseconds on this slide. So you really do want to keep these people in until you get below a PR of less than 0.3. Regardless of which, I don't even think the antibiotics matter at this point. It's keeping them on a monitor in a center that can put in a temporary pacer emergently if they need to. Okay? So again, it's got a pretty good prognosis, but when you get to higher degrees, third degree block, oftentimes you'll need a temporary pacer. But it's really rare to need a permanent pacer for Lyme. It usually just gets better because, again, if it's the inflammation, it's going to go away. Even if it's the bacteria, you're going to kill them off. Okay, let's go one more. This was just showing some of the cases of sudden cardiac death that were reported in the literature. I don't think I really need to beat that up. It'll be there if you want to look at it, but it just goes back and sees what they've been seeing. So again, it's not very common, but it does happen. And again, if you notice, it's oftentimes males and they're young. Okay, one more. So I think we should be looking at it for anyone with early disseminated Lyme disease, just get an EKG. Or the opposite, if you're in a Lyme endemic area and there are otherwise unexplained conduction systems, then you need to get Lyme serology. And if the Lyme serology is negative, then I would say it's very, very unlikely to be Lyme causing their heart block. And I think we should be admitting people with suspected cardiac Lyme until we get a PR that's less than 0.3 consistently for 24 hours. Long-term sequelae is really rare. Dilated cardiomyopathy, and there's no real convincing evidence of this. I will just review a little bit for you guys where it came from because I didn't put it on the slides. In Europe, within the past decade, there have been multiple case reports where they have had people with a dilated cardiomyopathy, and then at autopsy they find Lyme spirochetes. And there was one case report where they treated, I think it was 8 patients with a positive serology and a dilated cardiomyopathy, and their cardiomyopathy resolved. When they've done the similar studies in the United States, none of it has panned out in the U.S. So far, nobody's been that with dilated cardiomyopathy treated with doxycycline has had their dilated cardiomyopathy resolved. So I really think it may be a strain thing in Europe compared to what our strain is here. And at this point, I certainly wouldn't recommend that we take everybody with dilated cardiomyopathy and give them doxycycline because I don't think the evidence is out there for it. And with that, this is all I got today.
Okay. Stop share.
Yeah, thanks. Thank you for saving us, Jill.
Yes, that was great. So I just got to say, I give you guys credit for it's almost the, in December and you're still coming to tick-borne infection talks. That's great. That's really good. So this really did make me eye-opener that I should be getting EKGs on Lyme or more of my Lyme suspected patients than I have been. So I think that's probably, if there's one thing I would want out of this talk is have a very low threshold to get EKGs on your patients with early disseminated Lyme.
Okay.
Any questions, anybody?
He has a question.
Oh,
Okay.
you're on.
Yeah.
Hi, Dr. Collins. I have a question. You
Sure.
know how about anaplasmosis and we're like we should be using doxy for the children because the evidence is there.
Yes.
Did you find anything for the Lyme carditis for the children and instead of using amoxicillin when they're less than 8?
Not specific to carditis, but I would have to go back and look at what the IDSA guidelines, if they ever re-release them, say. I can't remember off the top of my head what they said about children in that situation, but my guess is it would make sense to use doxycycline the same way because you're not going to have to use it forever. The thing about it is if you treat it for 14 days, you should be fine even in children. And most of the time, this resolves. 14 days is enough. But I would love for those new IDSA guidelines to come back up where we can get another look at them.
Yeah, it looks like
I didn't
they closed the public.
comments. Yeah.
Okay.
So this is just me remembering off the top of my head what they had said in those guidelines. But it would be nice if we had them back because I can't remember everything I read in them now.
I'm looking
but
for them.
I appreciate it. I can't get them again. I tried. But yeah, cardiac Lyme, but remember kids too. It's there. So just have a low threshold to look for it, I think is the bottom line. And if you find it, I'd hospitalize them. I really would. If you get a normal EKG and they go early disseminate, I'd stop. I'd just give them doxycycline because again, it's rare to get this kind of problem. But if they have an abnormal EKG, meaning conduction system abnormalities, I put them in the hospital, even if it's just first degree. Assuming that you don't have an old EKG and they already had first degree.
Okay.
All right.
Go ahead, Ashley.
If we find any different information on the IDSA guidelines, we'll send it out to everyone. But other than that, I think we've got time once again. So I will send out a request for evaluations. Vanessa, I did get yours. Thank you. I'll make sure those get submitted. And other than that, I think we'll break for the Thanksgiving holiday and come back around December 12th.
Thank you guys very much.
Thanks,
Appreciate
everybody.
Thank you.
Bye.